Good morning. My topic will be pit temperature sealant. So, if you see the purpose of a pit temperature sealant, it prevents caries. In a primary tooth, there is no prominent pit temperatures, but in a permanent tooth, there are prominent pit temperatures. So, we need to close these deep pit temperatures to prevent caries. So, if you see the evolution of a pit temperature sealant, zinc phosphate was first used. After that, ammonium silver nitrate was used, but the retention capacity of these two was less, so there was a frequent dislodgement of a sealant. Then they tried prophylactic odontome. Prophylactic odontome was introduced by IR, and it was popularized later on by restoring with the amalgam restoration. This prevents the caries of a permanent molars, first molars predominantly. After that, they used a solution of a cellulose nitrate. So Buenacor was the first one to introduce etching with the phosphoric acid, later on bonding with the cyanoacrylate. Later many advances in pit temperature sealant and the advancement of a methyl acrylate has led to the present systems. The first colored sealant was concise white sealant. Later on, they used a sealant for even first and second molar. Pit is defined as a small pinpoint depression located at the junction of a developmental groove or at the terminals of these grooves. Fissure is a deep cleft adjoining the two cusps. So if you see the difference between a fluoride and a sealant acts on the pits and fissures only, whereas fluoride acts on the smooth surface. Now these pits and fissure sealant act by closing the substrate for the development of a bacteria. When these sealants are placed, there is no debris residing even after full. So the classification of a sealant, the first one is the first generation. In first generation sealant, they used a UV light. The disadvantage of a UV light curing is there is excessive absorption and there is an incomplete formation at its depth, and the intensity is variable, and the output was not uniform. So in order to overcome this one, they start off a self-sealing or self-curing resin. These mostly are unfilled and may be transparent, tinted or opaque. The third generation was light cure. They might be unfilled or filled. These have a better curing capacity than the self-cure, and the uniformity of a restored material after setting is good compared to this one. And the fourth generation is when you add a fluoride or any anti-cariogenic to this sealant, it will prevent further caries, which was the biggest disadvantage in the previous generation. And based on the filler content, we have a unfilled and filled. Unfilled abrade rapidly and the flow rate is better, retention is more, but filled are resistant to abrasion and sometimes need artificial adjustment. After 10 to 12 months, there might be a dislodgement of a pit temperature sealant. So in order to have a recall on whether to check whether it's on, we go for a tinted. Previously it was clear. So clear doesn't give any demarcation from a tooth. So we go for a tinted. Based on curing, we have autopolymerized and light cure. And the materials we use for pit temperatures are cyanoacrylate, polyurethanes and GAC. Bowen was first to introduce this GMA, and addition of bisphenol A and glycerol methacrylate have created a new era in the sealant. These fillers are more resistant to abrasion. And we have various types of fissures. You have a V-shaped fissure, U-shaped fissure, IK fissure, inverted Y, and I. Out of these, V and U have a better self-cleansing activity. inverted Y and narrow slit eye have a poor self-lensing activity. These are the various types of fissures. And the rationale for use of a sealant is they prevent pit and fissure caries, and benefit of placing in high risk surfaces or high risk patients is prevention of a caries, and we can evaluate frequently. Now, in order to go with the pit and fissure sealant, first thing we need to check is the caries risk assessment. Wide examination is required to check whether their patient is caries, higher caries risk or low caries risk. And the time since eruption, if the tooth is recently erupted, then we might prefer going for a pit and fissure sealant in case if it is high risk. In general condition of the mouth, if patient is already having multiple caries, then we might go with the prevention of a caries with a pit and fissure sealant. And the age of the patient, young, perm, then need a pit and fissure, whereas old who are resistant to caries or who are not prone to caries can be avoided. Medical conditions which exacerbate the caries content or oral conditions should be treated with a sealant. Now, for diagnosing of pit and fissures, first one is a tactile sensation. Now, if you pass a probe from one end to the other end, if there is a rough or any debris, we might be going for a pit and fissure. Radiographic evaluation, it doesn't give much, it doesn't need much radiographic evidence because it's an initial one or a zero one. Now, ideal requisite of a sealant is it should be a non-toxic, non-irritating to the tissues. It should adhere to the teeth as a thin material and extend period of time. It should have a good consistent viscosity. It should have a mechanical compressive and tensile strength for prevention of abrasion and retentivity. And low solubility and sorption. Working time should be good. It should be karyostatic and should be able to check even after recall appointments. And the indications are newly erupted teeth, stained teeth, and with no soft base, erupted teeth less than a year. Contraindications is no previous experience of caries, radiographic evidence of caries, self-cleansing, partially erupted tooth caries free for more than 4 years, and proximal decay, and in patients who cannot be isolated properly. If you see the indications and questionable, if the patient is surface caries, occlusal anatomy, if pit and fissure then don't go for a pit and fissure. Any questionable caries, go for a next PRR, and if there is a deep fissures, then go for a sealant. Technique for a sealant application is first preparation of the tooth, isolation, drying the tooth, etching the tooth, rinsing and drying of the placement of pollination sealant at occlusal elevation. Now for sealant application, first polish the teeth, remove all the soft bud button. You can go with the polishing paste or air abrasion. The abrasion system, we usually go with a 50 micron alumina. Second is the isolation of the teeth. If rubber dam is used, it gives a better retention. If patient is not cooperative, use for cotton rolls. And do etching for 15 seconds with the phosphoric acid. After that, check for a chalky white appearance. Now, if you see the SEM picture of this one, we have a deep tags. These tags represent the porosity after etching. After that, rinse properly and check for a chalky white appearance and apply a bonding agent and cure it for 20 seconds. Now we have various bonding types. Usually we use for a total edge. Now after that, you place a sealant and cure it for 20 seconds to half minute. Even you can extend it to 1 minute based on the curing capacity of the light. After that, check for a occlusal or after that, check for a occlusal height. If the occlusal interference is there, polish it or remove the excess one. Thank you. This is the pit and visual. After that, we need to check for regulation. Now, if there is a problems in either application or if air bubble is present, sealant should be ground to expose. Sealant should be ground to expose the bubble and refill with the same. If there is a porosity, reapply them. If the sealant is removed, then reapply the sealant. If there is decay on the sealant, remove the excess and place a PRR. If there is a loss of sealant, remove the it and reapply. And the recent advances of a sealant, we have case and releasing sealant, embedded bowl to prevent the moisture contamination, enamel lock, that is self-etching light temperature sealant, and flows temperature, hydrophilic, fluorescent PPA. So this is about a pit temperature sealant.